Shoulder flexion is the plane of motion where the arm is coming up towards the ceiling in this sagittal plane. And the typical range of motion for shoulder flexion is 180 degrees. I typically test it in standing, having the patient raise the arm as far as possible with the palm facing in, and then I'll apply some overpressure at the end of the motion to ascertain the quantity and the quality of those few degrees at the end range of the motion. But if I need more detail and more clarification, or if it's very specific and important for that patient's presentation, I will certainly have the patient lie on his or her back and test shoulder flexion. In that position, it takes out the thoracic spine and neck a little bit more because they're supported on the table, but I still want it to get to 180 degrees. And when I apply overpressure, that means that I should get the arm pressing into the table. So it looks like this. Shoulder flexion all the way back. And then if I apply some overpressure, I should get that arm resting on the table. So shoulder flexion is just one of the many planes of motion. I test for the shoulder. The shoulder is one of the most mobile joints in the body. That's why it's the most dislocated joint in the body. But shoulder flexion tells me a lot about how the shoulder is behaving, but it doesn't necessarily incriminate the shoulder if there's pain or loss of range of motion in flexion. The thoracic spine plays a role in shoulder flexion, as does the neck. So I take it as a baseline in part 2 of my orthopedic evaluation, and then I apply the tests, most specifically repeated movement testing, to see if shoulder flexion was limited and or painful, what happens when we move the neck this way, or move the thoracic spine this way, or move the shoulder joint this way, and how the shoulder flexion changes or does not change starts to give me a clearer understanding of the possible diagnosis.